outcome, whether it is a scoliosis due to AS, adolescent idiopathic scoliosis, or a neuromuscular scoliosis. But these are not same. The incidence of complication, the perioperative period is around 10 to 30% or 10 to 40%. Neurologic complications like any weakness of the lower limb, respiratory complications we have discussed, and infections and surgical complications Dr. Ashok has already mentioned. So I will go through how to prevent that, and we had an extensive discussion on nutrition, and these patients especially will be having GERD and hiatus hernia, and there may be aspiration for these patients, and we have to be very careful to roll out to track this condition, and we have to get an opinion from the expert opinion from the nutritionists and speech and language therapy, and we have to supplement all these whatever the deficiencies are there, and these patients may need nasogastric or percutaneous gastrostomy. And the pulmonary function is the most important thing in terms of what is the indication, timing of the surgery and the post-operative outcome. And there are so many things we have discussed, and the pre-operative good respiratory rehab is very important. And the complication part, we get 20 to 50% of aspiration pneumonia, and that is the most common complication, even though pneumothorax, hemothorax are there. And post-operative, because of the post-operative anesthesia and medication, there can be sedation, pain, which leads to decrease in the respiratory muscle strength. And one of the important things we have to discuss with the patients and bystanders regarding the post-operative ventilation and tracheostomy before surgery. And any case like it will be usually seen by neurologist or a pediatrician or pediatric neurologist, we have to get a proper treatment for the control of the muscle spasm and other seizures and other neurologic condition, and we have to get a help from the pediatric nursing care and social service team for the other financial or support. And the most important part is the neuro rehab. We have to the musculoskeletal part, pulmonary part, occupational therapy, and the wheelchair part. You need a good physiotherapy for the control of the posture, support. You may need a lateral pads. And these patients in the post-operative period also, they need after the surgery, the position of the sitting, balance, everything changes. So post-operative rehabilitation is also very important. And if there is a deformity is mild, it can be treated with a soft braces like a lycra body suits, but rigid bases are given in some supportive from the later part. That is already been discussed. And in the lower limb, usually the ideal musculoskeletal for the hip, 90 degree of the hip, 90 degree of the knee, and the 90 degree of ankle. That is a good functional position. And thoracic deformity has to be assessed very well. And halo gravity, if there is a stiff curve, halo gravity traction is applied. We apply multiple planes into the outer table of the skull and the traction is applied. If the patient is on wheelchair, we apply on the wheelchair. If the patient is ambulatory, we can put it on walker. And usually we start with a 10 or 20% of the body weight and increase up to 50% of the patient body weight and continue for 4 to 6 weeks, which helps to improve reduce spinal curvature or scoliosis, improve the pulmonary function, improve the nutritional status of the patient and overall status. And we have to evaluate the GIT, genitourinary system. And pediatric cardiology, as parasol deformity is very common, it can lead to pulmonary hypertension and core pulmonary. All these has to be taken care in the preoperative period. A healthy child means if the child is gaining more than 2.5 kilogram weight per year and vital capacity more than 50% and sitting height increase more than 2.0, which is very realistic this thing. But we get a amount of most of the patients with the vital capacity less than 50%, co-abdominal more than 50, kyphosis more than 60, weight loss usually will be less than 20, and with other comorbidities. When a patient coming for scoliosis surgery, we take a detailed history, take an X-ray in sitting and lying down position, and we take a traction X-ray to assess the flexibility of the curve and look for the pelvic obliquities. And during position, we have to be extremely careful to pad all the parts. And anesthetic gas, usually we give intravenous anesthesia, which has been discussed in detail. And usually during exposure, we maintain the mean arterial pressure around 50 to 60 millimeter, and during correction, we use around 60 to 70 millimeter of MAP. And blood loss, we use tranexamic acid Deliberate hypertension is provided by the anesthetist, and you can use a local hemostatic agents like piping or something like that, and you can use bone bags for the bleeding surface from the bone, and you can use a bone scalpel or bone cutter for doing an osteotomy, and you can use a bipolar muscle. And if there is a bleeding, you can use a self-salvage, and rotem and tech criteria can be used for the transfusion purposes. And intraoperative neural monitoring, IOM, that is the most important part of the any spinal scoliosis surgery, which gives a time at the time of the whatever maneuvers we can assess whether the spinal cord is damaged or not. And coming to the screw strategy, the armament, we have to be well equipped with all implants like all diameter screws, hooks, wires, cross connectors, everything. Usually we go to the pelvis as per the protocol, and in the fixation we use S2 iliac screws, and we put all the screws and we use a cantilever method to correct the deformity. We start from you can start either from the pelvis or you can start from the top, and during any manipulation you have to increase the DP to prevent damage to the spinal cord, and MAP should be around 70 to 80 millimeter. And the pattern is try to make the correct the pelvic obliquity, contour the rod, and the most important thing is contouring is maintain the sagittal violence. We are not worried about the scoliosis correction. Maintain the sagittal profile, that is the most important. And after that, you have to be very careful in closing the wound. You can ask, you can get a help from the plastic surgeon if needed. Vancomycin may be added when you suspect an infection, and negative pressure wound therapy can be used in a high risk patients. And extubation, it can be usually done by intensivist or anesthetist, and usually postoperatively we continue analgesics and monitor the ICU. And the most important thing is it is a multimodal anesthesia, and as early as possible weaning. And the neurologic complication in this modern area with all this neural monitoring, all advanced technique, is only 1.1%. The most important worried complication is the postoperative infection, which is around 4 to 14%. Most are superficial, but deep infections are very dangerous. If there is any pattern, if there is an increased discharge, pain, or inflammatory markers in the counts or something like that, you have to consider that is a deep infection. Deep infection means any infection below the fascia. That has to be taken in seriously. You have to go for most of the organisms are staphylococcal, and gram-negative organisms are very common in this condition. And if there is an infection, you can get an MRI or ultrasound to look for any collections or infection, and the treatment is surgical debridement. You should not start antibiotic before getting a culture, and try to get a culture always, and depending on the culture you can start antibiotics. And usually 90% of the infection will settle with multiple debridements, but the problem is wound closure. Sometimes you might have to take a suction negative pressure dressing, or you have to get a muscle flap or plastic surgery procedures. Another complication is the decompensation because of the undercorrection or overcorrection, because we are operating in prone position. Whenever you make the patient on sitting position, then only we can assess what is a complete correction which is done. So sometimes it leads to postoperative decompensation. As Dr. Ashok has mentioned, always try to go to T2, and lower I can be, usually it is described as pelvis, and avoid stiff rods like Ashok mentioned, titanium rods, and you can use gentle methods. So try to complications you can expect, and the most common complications are respiratory failure. You can use non-invasive ventilation and early bronchoscopy if you suspect some mucus plugs. And if there is a massive bleeding, you can use a rotem, TEG direct resuscitation, pause correction, and warm the patient. If there is a signal loss during correction, that means if there is an MEP loss, you reverse the whatever maneuver done, raise the mean arterial pressure, increase the hemoglobin, increase the temperature, and control all these things. So this is one of the case with a severe deformity. This was the X-rays in APL lateral. Even the traction X-ray shows not much of correction. This is the after hydrogravity traction. One more minute. This is the last. So this is the intraoperative position. Even after during surgery, even after during correction, you can see that there is not much of the deformity correction. So and you can see the lower limb contractures. You can see the wires in the lower limb, which is the MEP connection. And this was we have put a multiple wires in the, because the pedicles were very small and we could not achieve pedicle cannulation. And this is a final value. So take home message is that surgical treatment is not for every patient, every neuromuscular scoliosis patient, and it is not for every surgeon, and it should be done in a, only in a specialized centers with all these backup facilities. And surgeon should be only the part of a multidisciplinary. We are only part of a whole team. Thank you.
What does not happen at all, or do any complications happen if you do a premature fusion? My question is to Dr. Ashok.
That's a good question to tackle. The thing is, sometimes your hand is forced. If there is a way you can get it, if you're talking about AAS or non-SMS coding. In SMS coding, most of the time we don't have an option. If your curve is say 70 or 75 and any other 9, we have to take the child. And the previous worry was when there is an anterior growth left and the child grows during puberty, that's got a function. With anterior segments going hyperload, so then we got it. But with the 3-column countries, the pedicles grows at all levels. Thank you, that actually doesn't happen.
And I apologize for not being. In addition, it needs